Good morning, everybody. And I know we're going to have other people join in as we get going here. And Brian, please feel free to interrupt as I go through this. I prepared, and this is based on a few conversations that I've had with some of our clients over the last few weeks about getting good conversions. And when I say conversions, I mean taking the patient from where they came in at, what their thinking is, into a commitment, into what you're delivering as far as your care plan, your unique care plan. So converting people onto care plans without compromise, without accepting them as pay as you go, without giving them some sort of a break in fees, that's really important. It's important, obviously, for you as a business and building your practice and obviously your income, but it's also important for the health and benefit of the patient, their long-term commitment. So that's what we're going to talk about today. So day two really is a bridge point, and I've prepared some information here. So I'm going to share my screen. Give me 1 second here.
Just as you
And
bring that up, Colin, I think what you just said, I want to restate it because I think it's such a huge point where a lot of docs, and not maybe not even the docs, but I'm going to tell you your team struggles is until you fully grasp the principle and what it is that gets offered through your office, the benefits patients get from just being a part of your office. A lot of times at lower levels or newer staff or younger staff, it's seen as a sale, right? And don't get me wrong, like is a sales transaction, but what we charge for care is so much less than the value that patient is gaining in their life because of being there. So you should really be looking at these pieces as you're going to deliver. It's like when I'm training with my team, it's like if we're talking about referrals, it's not like, hey, give us the names of your people. It's more like, hey, like we have a stack of gold bars in the office. We're looking for people to give them away to. Would your friends like a gold bar? Like that needs to be the heart of the conversation. So I know Colin said it matter of factly. I just want to double down on that piece because it's so huge. If not, you walk into a day two and it almost feels like it's a you versus them, or you're trying to win them in the conversation. It's you're coming and you're delivering this solution, and so you should be coming with arms wide open. And it's like you're there to help them.
awesome. Thanks, Brian. That is so important as we enter into this. So first of all, as we get into this, and I've titled this talk Psychology of Conversion, because we're really going to talk about changing that patient's mindset. So here we go. So these are some of the things, the keys to conversion. So let's try to identify, first of all, what is the patient thinking on day one? Well, remember, whatever way the patient entered into your office, whether they're from a referral, whether they came from online marketing, whether you did a talk at a company, whatever that is, let's just make the assumption that patients generally have put you into the category, they've put you into the box of being a treater of pain. So they're coming in with some level of symptom. Let's assume that they know nothing about chiropractic. They know nothing about the correction of subluxation. They know nothing about restoring function to the body through removing interference from the nervous system. They know nothing about that. They're worried about getting rid of pain, and they're worried about getting their life back on some level for the things that they can't do. So let's just assume every single patient thinks that way. And if we can start from that point and then have an outcome, so then we say, okay, well, what do we want them to understand? If you're practicing a level of corrective care, if your goal is to correct spines, to adjust spines, to remove interference from the nervous system, and allow that person to have the opportunity to express their full health potential, their full life potential, because you've removed that interference neurologically. And we want them to understand that subluxation is a detractor from their ability to live a full and complete life, physically, mentally, spiritually. So let's just assume that right from the beginning. So we want them to understand that. And so therefore, we have to perform our day one accordingly, which means we meet them where they're at and we help bring them from where they're thinking of that pain-based model into a totally different model. So let's remember that day two works much better when you have a great day one. And if your day one is focused on introducing the idea of subluxation, of introducing the idea of nerve interference, and your examination on day one has been structured to measure and start to collect metrics that you can monitor. So, in other words, what I'm saying is that your examination needs to be full of tests that give you data that are outside of the pain-based subjective model. You need to record these objective measurements. So whether that's measuring the x-rays, whether that's getting a neurological scan or HRV values, or doing some sort of a postural check where you can actually quantify the posture in some way, or a range of motion check where you can quantify the range of motion. So this data can be monitored through their care, and you can actually show the patient that they're improving regardless of how they feel. So let's make sure that we're starting on that premise. And if for some reason you're still doing those, orthopedic type of tests on day one, if you're still doing pain-based models, if your examination, your consultation is still highly focused on asking them characteristics about their pain, or a lot of questions about their pain, all you're doing is reinforcing in their mind that you are a treater of pain. And if you're trying to build a wellness practice, but you're still doing that, you're being incongruent. Okay, so let's just identify that first. So, what is the ultimate outcome? We want them to obviously understand that level of thinking, and we want them to convert onto a care plan, and our care plan is going to be congruent with what we're trying to correct, whether that's some sort of corrective change in their spine, in their neurology, to get them to a point where then we can maintain it or prevent it from going back. Okay, so that's kind of the thinking on day one. So if we go into day two with that thinking and we've made those metrics, then we pre-frame day two. Okay, now remember, I think in the conversion process, day two is the most important day. It really is. So let's take a step back and just say that if you're still providing any level of adjustment or quote unquote treatment, and I don't like that word treatment, but if you're performing some level of care on the first day, my suggestion is think twice about that, because again, then you're just reinforcing what the patient came in for. All right. And if it's an acute situation, but at least have a system or a process where you give yourself some time to look at the data you've collected in your exam, maybe a couple of hours or whatnot, have the patient come back on the same day, and then perform your adjustment or your quote unquote treatment. At least then you've given yourself a chance, and in the patient's mind, you've given that person the idea that you're looking at their exam findings. Okay. Then you can enter into the day two. So whether the day two happens on the same day, it should be at a separate time than your examination, but preferably the next day. Okay. So let's just clarify that. The day one phone call is a great pre-frame for day two. And when you're doing your day one phone call, and again, I want to clarify, it's a phone call, not a text message. You're saying to that patient on the day one phone call, I wanted to call you because I looked at your exam findings and I am concerned. Okay. And these are really important things to do, because you are changing the paradigm, changing the mindset of that patient. So I'm concerned. I did find subluxation. I did find abnormal spinal alignment. I did find degenerative changes. I did find, if you want to say arthritis, whatever you're using to be unique and different, to take that patient from this is just a simple muscle strain or a simple pain, fix my pain, to a more structural and neurological type of thinking. Okay. So that day one phone call. So I am concerned. It's worse than what we thought. It's going to take some time to correct, but the good news is that absolutely this is something I can help you with. I will see you tomorrow. I'll have more information for you. And if you'd like to go ahead with your first adjustment after we talk, then we can start with your first adjustment. So at least it's a pre-frame into that day two. And then when that person comes in on the day two, this is really important. And we trained our team on this all the time. And we've talked about this before, is that we positioned it in the fact that we were there to save somebody's life. And when I say that, and a lot of people look at me like, when chiropractors look at me and I say that, they kind of look at me like I have three heads. Because here's the thing, is that a subluxation is not going to kill you, but not knowing what a subluxation can do to your body over time will kill you. That's the difference. So understanding that subluxation is a precursor to decay, disease, dysfunction, and early death, that's what I wanted to make sure my staff knew. And we trained on this all the time, whether it be through studies, whether it be through articles, whether it be through ripping people out of the medical system, because if they try to get pain relief treatment by ingesting chemicals or going for surgery, that's going to kill them. That's going to shorten their life. Because even though now they're still dying, but they're just dying comfortably. And we talk to our staff about this all the time. So what was really important was that staff greeting when people came in. We didn't want our staff to go, "Hey, Bob, how's it going? Good to see you." It was concern. The person was coming in and we're about to save their life. It was, "Bob, we're so glad you're back. Dr. Collin was really concerned about what he found on your exam findings yesterday and wants to get started with you right away." So it was, again, the thinking was we wanted to shock that patient. It was it was a virtual, and I'm going to call this a virtual slap in the face, because they're coming in thinking this is no big deal. It's just a tweak. It's just a simple muscle strain. It's just a flesh wound, you know. But we needed to help them to understand that this is a serious problem. They would bring them into the room, and then the doctor greeting was the same thing. So I'm going to ask you guys to ask yourself, when you're going in for a day two, how is your first interaction with that patient? Is it, "Hey, Mrs. Jones, nice to see you again"? No, it's "Mrs. Jones, I'm glad you're back. As I mentioned on your day one phone call last night, as I mentioned on the phone last night, I am extremely concerned with what's going on. And here's the scripting." And I'm going to say you can vary this scripting however you want, but this is very succinct and very concise. So, as I mentioned on the phone, I am concerned because you do have subluxations and this condition is worse than what you thought. And think about this. And then I would pause. Give the patient a chance to process this. And I've called this is the virtual slap on the face. I am purposely changing their paradigm. In fact, on a scale of 1 to 10, you are an 8, you are a 9, whatever that is, whatever you relate it to. If that person had subluxation patterns, if they had a kyphotic neck, if they had degeneration, disc degeneration, osteophytes, whatever, they're an 8 or a 9. And here's where it gets really important. Your nerves have been damaged, and that is the root cause of your pain. This is not a simple muscle strain. It is a neurological problem. My concern for you, and this is where I would really get serious, and I'd be knee to knee with them, sitting down, and I'd be looking them right in the eye, and I would not lose eye contact during this time. My concern for you is that the damaged nerves also supply these vital organs. Huge point, because now you're relating their muscle problem, their muscle strain, their lower back pain, their sciatica, their headaches, to a deeper problem that could affect the quality of their life and the quantity of their life. So these organs are already being affected because the same nerves that are supplying these organs are the ones that are damaged and causing your pain. If this is not corrected, it will get worse and it will affect your function and your life. And that's it. That I don't get into explaining anything. I don't get into teaching. This is not the time to do that. This is the time to change their mindset. And I do that very consciously, intentionally, and slowly. And I'm doing it with concern, and I'm looking them in the eye as I do that. And I want them to have a visceral response. I want them to have an emotional response. That's what I'm looking for. Okay, that is so vital. When I feel I've done that correctly, then I can move on to the next step. And then I'll start asking the rhetorical questions. Okay? And here's just a very simple example of the rhetorical questions that I would ask. So after we've had that short little interaction, I visibly see that I've got to them and their mind is going 100 miles an hour. That's when I pause and I, again, let them process. You can't speed through this. So I'd look them in the eye and say, if you ignore this, is this problem going to get better or worse? And I wait. And I'll wait. And I literally wait them out. And I'm waiting for them to respond. And I'm looking them in the eye the whole time. And it can be the most awkward situation. But remember, my heart is trying to change their life. And if I don't change their mind, I have done nothing for them other than help them be more comfortable. So I'm trying to change their life. You can't save somebody's life until you change their mindset. And this is where we change their mindset. So they're going to respond by saying worse. And then I say, if you just took meds or you just got symptomatic treatment like physiotherapy or you saw a chiropractor that just treated you for the pain, again, would this problem get better or would it get, and I'll pause and I'll wait for them to say worse. Exactly. So now here's where the conversion happens. So then I would ask them after we've gone through those questions and I know they've answered and I've given them a time to process those questions. Would you like my help to correct this problem? Would you like to get to the root cause of this problem? And I wait for a yes. So again, I'm letting them make the decision. And if they say yes, okay. If you want my help, I'm going to invite you to go through this process with me to help you to understand exactly what's going on and give you some options to get the best correction and make the best decision moving forward. Would that be okay with you? Yes? Great. So now they've given me permission to take the next step. Okay. That 2 minutes is the most important time, in my opinion, in the life of the patient. You either have saved that person's life and you've created a warrior patient because you've taken them from that pain mentality into a, okay, I understand how important chiropractic care is in my life now. This is now a priority for me. This is the big difference. So, and I'm going to say, so whether you're doing a day one, day two, where you do your report of findings on day two, or whether you do a day one, day two, day three, where you do a doctor's report and your X-ray findings and whatnot on day three, it doesn't matter. Those two steps, so the day one and then leading into that first part of the day two, that's what is so vital, so important. Okay. And I'm going to address something here. And maybe Brian, you might want to comment on this. I talked to one of our clients the other day about the idea of being a scare tactic or using a scare tactic. And I want to say this because for a layperson or for maybe a chiropractor who's just not on the same wavelength, that system might look like a scare tactic. Well, I'm going to say you can label it however you want to. You can call it a scare tactic, whatever it is. But and here's my thinking is that if I didn't do my job properly, that person would come in, get a couple of adjustments, feel good, and then they would go home and nothing would get corrected. Their spine would continue to degenerate. Their neck would still be in a very alordotic position or getting worse. Those bone spurs and osteophytes would still be getting worse. That disc degeneration would get worse. I'm allowing them to die comfortably. And I'm not willing to do that. So that's just my position. And if I want to help them understand that lifetime chiropractic care for themselves and their family is really vital and important, that's why I go through it like that. So call it a scare tactic if you want. And I always say, I wish somebody would have got my mom when she was taking 13 different medications and eating terribly and not looking after herself and thinking that chiropractic care was uncomfortable, so she didn't get it. I wish somebody would have given her a scare tactic to change her paradigm because then she'd still be with us. So anchor to what you really truly want and truly believe, and don't be afraid to take a stance on that.
I would say it's only a scare tactic if that's your intention, right? Like a mentor of mine, not in the chiropractic world, leader in a totally different field, but said to me, like it's like if you're coming from your heart, you can say some pretty aggressive things, but they land properly because you're saying it out of love for the person. You're not trying it to scare them. You're saying it to be honest, and you're trying to give them options for a different path. So when you and if you hear the stuff that Colin said and that feels salesy or scare tactic or whatever, I'd encourage you to go and just dig into the research to understand if this goes uncorrected, where does that end up? Because I always found like the easiest thing for me to get my mindset right, where I didn't feel I was in there trying to convince anybody. I was in there more having a conversation with them, and more like, leader, take my hand, let's go this way, versus like, hey, I'm trying to convince you to do this thing. Because I was there at one point in my practice. That really came when I really understood and took this viewpoint of, if this person just stays on the same road they're on right now, doing what they're currently doing, where would they be 10 years from now? Like, what does their life look like? What are their abilities like? What's their health like? What are their relationships like? Versus if they join the practice, they get in the office, they get corrected, and they're on that trajectory, where does that spot end up? And they are two radically different pieces. Once you start to be able to perceive that, this does, like, saying things like this doesn't come off hard. The patient's like, oh, it's like an awakening for them. and they feel more in control because it's likely maybe the first time someone's been honest with them. Because I'm like, I just had a patient who brought an MRI in the other day, and it's terrible. There's all these retrolisthesis. There's like 4 crushed discs, couple bulging, this and that. And I'm like, what they give you for a solution? Nothing. Right? It's just they tell you what's wrong. Versus like, hey, have you thought about this? What do you want to do here? Like you're putting them in the driver's seat.
I'll tell you a quick, funny little story. I remember grade 4, grade 5 science fair, and this is back, well, early 70s. And I remember one of the students had set up had partnered with the Lung Cancer Association, and they had the mannequin. And I don't know if you've ever seen this, but the mannequin that would actually smoke the cigarettes, and it was hooked up to a vacuum through the lungs. So there was a vacuum hooked up to it, and they would actually light a cigarette and put it in this mannequin's mouth. And the mannequin would then, because the suction is going through with the vacuum, the smoke would be inhaled, and there were these 2 jars full of cotton that the smoke would eventually go through in the lungs. And through the course of the science fair, you could see the lungs starting to get black because of the smoke. And the idea was it was a scare tactic to scare kids out of smoking. And I remember my mom at the time, of course, was a smoker. And she actually used that term scare tactic. And so it labeled itself in my mind, but now I look back at it and go, I wish she would have paid attention because people that looked at that as scare tactics, maybe that was their way of blowing it off, thinking this is not as important to me or I don't want to really understand the truth. However, that was just a little example of what we're trying to do. So I want to make sure that I do my job in helping that person change their mind, change their paradigm. And that's why I call this the paradigm shift.
Well,
So
also
now,
like talking about that, like even the Heart and Stroke Foundation, Canadian Heart and Stroke Foundation, like they had that big ad a few years ago. It's like your last 10 years or your next 10 years or something. And they show like it's like a split screen. It shows a guy who's enjoying, you know, life with his grandkids and doing stuff and holding grandkids and at birthdays. Or they show, and on the other side of the screen, they show someone helping do up his buttons and he's on an oxygen tank in the hospital and all that sort of stuff. Like it's the reality. If you do something or you don't do something, sometimes people just need to know. They need to be told. If you don't do anything, you're going the wrong way.
yeah. So the next part of the paradigm shift, and I'm going to pre-qualify this, is that here's getting the proof. Like this is taking the weighted X-ray, taking the re-X-ray on day 2. And here's the thing, and here's the caveat to this, is that if you don't have X-ray in your office, if you're not fully invested into home care, that every single person gets home care, or if you don't have the therapeutic stations in your office, like the Vibe plates and the head weights and the Cerviguards and the wall traction units, if you don't have that set up, don't do this. Like honestly, it would be like trying to put mag wheels on a Prius. There's no point. But if you're fully invested into getting corrective care and you wanted to use this day 2 to get the proof, and I'll be honest with you, I never did this. This was not part of our plan. We had great success not doing this and getting people onto a longer term care plan. But this is a great way to show people that what you're going to do, it gives them the proof that what you're going to do is going to get correction. So this is the retest is the way to determine the exact type and amount of care that you will need to get this problem corrected. So maybe you do your day 2 weighted X-ray or your Cerviguard X-ray or motion study, whatever it is you're going to do, or maybe even you have a posture unit or posture pictures and you're going to do some weighted posture pictures to have a day 1 picture and a day 2 picture that's weighted after they get adjusted, after they do their therapies, and maybe with weights on their head during that X-ray. And then you can show them the difference and show them what your expectation was to give them some sort of a social proof that the care plan works, that what you're talking about works. If you're not fully invested into that, don't do it. That's my suggestion. So then we can go into say, okay, well, if you're going to provide your first adjustment on day 2, pre-frame and deliver that first adjustment. And here's some tips on this is that remember, again, this is all about the paradigm shift. I would never go for their first adjustment and go all gung-ho and adjust them head to toe. I didn't see the point in that. First of all, from a time perspective. Secondly, this is them dipping their toe in the pool. They haven't committed to anything yet. My intention was to explain exactly what I'm doing with that adjustment is that all I'm doing is starting the healing process. And my intention is to remove interference from the nervous system so that their nerves have an opportunity to start to function differently. And I would always begin at the opposite end of the spine as the symptoms. So if they had lower back, I might only adjust the neck, maybe the upper thoracics. If they came in with headaches, I might only adjust the thoracics and the lumbars. I typically would stay away from the pain area because intentionally I want them to understand. Again, I'm trying to change their paradigm. They might be thinking my pain's all here, but I'm adjusting them at different ends of their body. Well, again, I'm purposely intentionally doing that so that they start thinking the adjustment is not a treatment for pain. So that was one of my techniques that I specifically intentionally did was I would not adjust the area of pain on day 2. And I would explain why. Because we're just starting to release their nervous system and allowing their body to start to readapt at a different level. And it would manage their expectations. So we always qualified 3 things could happen. They may get worse, they may not feel anything, or they may feel better. It doesn't matter. Those are all expected. But the most important thing is that over time, we're going to correct those dysfunctional areas, correct those subluxations in the spine to allow their nervous system to function better and differently over time. Okay. And then we would set up day 3. Okay. So if you're doing a day 3, first of all, if you're doing a report of findings on that day, you would then go into your report of findings after that. Some people would go into the report of findings before they do that adjustment and get commitment then. If you're doing a day 3, we always set up day 3. And then I would ask the patient after they've been adjusted, because of the concerns that I see on your x-rays or on your exam findings, most people ask me, and this is a great way to ask this question, like, oh, we want you to bring your spouse, or we want you to bring your husband, your wife to the doctor's report. And this is, I'm going to say, I actually got this from Brian years ago. Most people ask if they can bring somebody with them. Like, this is just a common thing. We're not telling you to do it. Most people want to do it. Most people ask if they can bring somebody to see their x-rays and help them make decisions on what type of care and financial commitment they want to make into their chiropractic care. Is there somebody that you'd like to bring with you, or is there somebody that you think would be there to support you? And usually it's the spouse. And that's how we got a large percentage of spouses to come to the doctor's report. And then always, I would say, remember that these problems that you're having are very genetic. Spinal and nervous system dysfunction are very genetic. Do you have kids? Or how many kids do you have? And have they ever been checked? Oh, my kids don't have any pain. Well, again, that's not the point. That's fantastic. But would you like them to have the same problems that you're having as they get older? Wouldn't you like to know if there's a problem there that could have been prevented when they're young? Of course. So we're going to make time to get those kids scheduled. I would do it at day 2. We would do it again at doctor's report. That was a consistent thing that we did. And then the handoff to the team is very important. Now, I always had a tech CA that was with me through that entire exam. So the handoff happened right there. But if you don't have that and you're doing your own exam, you take them to the front desk and you do it right in front of your front desk person and say to that front desk person, hey, Diane, John just got his first adjustment. I've just explained to him what we found on the exam the other day, what I saw in his x-rays, what I saw in his nerve scans, what I saw in his posture evaluation. As I mentioned to John, and as we talked about earlier, I am very concerned for what I found there. And I want to set up some time for John and Marcia to come in and see those exam findings tomorrow night, Tuesday night. Can you please set that up, reserve time, reserve space for them, make sure that there's space for both of them to be here to see those x-rays, okay? So I've done that, John's standing right there, Diane's right there. I've connected the two of them together. So now when Diane sets it up, okay, John, I've got you and Marcia set up for tomorrow night. Is there any chance that you can't make it? So she would go through her scripting at that point and get the day 3 set up. Always that night. And again, never miss this. Day 2 phone call, really important. Whenever you do a first adjustment on somebody, it's really important to connect with them. It can be a very emotional experience. You never know what's going to happen with that person, especially if they've never been adjusted before, or even if they have been adjusted by another chiropractor. You don't know what level of care they've had in the past. So let's assume this is the first adjustment they've ever experienced. I would always call and say, hey, I just wanted to check on you. How are you doing after your first adjustment? Oh, I'm really sore. Fantastic. I'm really actually happy to hear that. That's great. That means we made some immediate change. That's temporary. And remember, the healing process takes time. Okay. And you may experience that discomfort the first few times. That's a good thing because it means your body's adapting and we're removing interference from the nervous system. I feel so much better. Fantastic. That's wonderful. That's a great response. Remember, your body's adapting and it's going to take time to make that correction. And then, and I would always close day two phone call is we've got you set up for the doctor's report on Tuesday night at 7 p.m. And I just wanted to confirm that you and Marcia are going to be there. Is that right? Fantastic. Good. I'll look forward to seeing you then. Awesome. It was very short, very quick, but very intentional. Okay. And that sums up day two.